Welcome to this talk. Today we'll be talking about cerebral palsy. This is going to be a compressed lecture because cerebral palsy is a very broad topic, and I will try to cover the basic things about cerebral palsy. We'll be talking about the types of cerebral palsy, and we'll be talking about complications and a few of the treatment modalities that we can offer to the children who are suffering from cerebral palsy. So, without further wasting our time, let's dive in and get started. Now, cerebral palsy, by definition, it's not sort of a concrete term, it's an umbrella term which is used for conditions in which there is non progressive disorder of movement and posture. So, the underlying pathology is non progressive in nature. So, it's not progressive. This is very, very important. A non progressive disorder of movement and posture, which is caused by injury to the neurons in brain. So remember, our brain consists of billions of neurons, and if these neurons are injured in one way or the other in such a way that it causes disorder of movement and posture. So it can be movement and it can be posture, but it is non-progressive in nature. So the lesion itself, whatever damage has been caused to the neurons, that damage has been caused. That doesn't spread. So what it leads to a disorder of movement, it leads to a disorder of posture, but that is non-progressive in nature. So this is very, very important that you should understand that this is a non-progressive disorder of movement and posture, and compare it with those disorders in which there is progression. So, for example, neurodevelopmental disorders or those disorders in which the pathology is slowly and gradually spreading. So, that what that would lead to, it might lead to disorder of movement, it might lead to disorder of posture, but that would be gradually worsening with a period of time. Why? Because the original lesion is slowly and gradually expanding. So, that would be a progressive disorder. So, by definition, that would never be cerebral palsy. So, cerebral palsy is basically a non-progressive disorder of movement and posture. And this is very important because I've seen that many kids who have got progressive lesions, they have been, classified as cerebral palsy. Cerebral palsy is very important that it's a non-progressive disorder of movement and posture. Now, it seems like that probably we are talking about motor neurons and we are probably talking about movement and posture only. But remember that in brain, when the neurons are damaged, primarily the motor cortex are those neurons which control your posture. They are, when damaged non-progressively, it can lead to cerebral palsy. But usually the underlying pathologies that cause destruction of these neurons, that not are not only selective in causing this sort of destruction of the motor neurons, they can cause destruction of other neurons as well. So it can be associated with other features as well. Like, for example, it can be associated with intellectual impairment if the cortical neurons are impaired. It can be associated with problems in vision and hearing if those neurons are involved. It can be manifested as seizures as well. So remember, it's not only a disorder of motor and posture, though by definition that is basically cerebral palsy, but it can be associated with other issues at the same time. So it's not uncommon to see kids who have got non-progressive disorder of movement and posture. They also have got disorder in their vision, they have got problems with their hearing, they've got problems with seizures, they've got like problem with intellect. So these things can be associated together. Now, incidence in UK is around 1 in 400 live births. So, and again, more so in premature births. Moving on and talking about the etiology. The most common reason for a child to develop cerebral palsy is prematurity. By and large, this is one of the greatest factors which causes cerebral palsy. So, prematurity. Probably, I would say 80 to 90% of the kids who develop cerebral palsy have got prematurity as a risk factor. So, what is so so special about prematurity that it leads to cerebral palsy? Basically, prematurity is all about less maturities. Why that's so called premature? Because things are not mature, and the same goes for the developing neuron. So less mature neurons, remember for them, there are more chances of insult. So these babies, when they are born, they can suffer from different types of insults. Those could be infections, those could be less oxygen supply. So these neurons are not resilient. They can very easily get damaged. And when they will get damaged, that would manifest later on as a disorder of movement and posture, which we would call as cerebral palsy. So prematurity by and large is the most significant risk factor for cerebral palsy. Then we come down to the prenatal infections, torch infection. And the torch exonym stands for, T stands for toxoplasmosis, O stands for others, and these others you've got the syphilis, you've got now these days Zika virus and HIV. Then in the R stands for rubella, C stands for cytomegalovirus, and H stands for herpes simplex virus. Now, these infections, if they occur prenatally, these infections are notorious in the sense that whether these infections, whether they are parasitic or bacterial or viral, then the damage caused by these organisms, this not only damages the different structures in the developing baby, but they also can destroy neurons, developing neurons, and those developing neurons later on would manifest as cerebral palsy. So prenatally, one of the biggest risk factors are your torch infections. Then perinatally, when a child is born, usually. So perinatal events, which could be anything, that could be premature rupture of membranes, that could be prenatal infection in the mother, that could be a prolonged labor. All these, or that could be cord around the neck, or if there could be fetal factors, there could be maternal factors. Irrespective of whatever the factors are, whether you remember them or not, the ultimate endpoint of that is what we call as hypoxia. So there is less blood supply or less oxygen supply to the fetal brain, and that leads to damage, which we call as hypoxic, ischemic, encephalopathy. So hypoxic, ischemic, encephalopathy leads to destruction of the neurons, and that will later on manifest as cerebral palsy. Then postnatal events can also cause cerebral palsy. So early infections in the form of meningitis, so or sometimes neonatal sepsis, early onset neonatal sepsis, meningococcemia. That can also cause cerebral palsy later on. Similarly, prolonged jaundice leading to kernicterus, in which there is deposition of the bilirubin in the basal ganglia, that can lead to cerebral palsy. So these kids might develop like cathetoid or dyskinetic types of cerebral palsy. Now, on the right side, if you see, like eventually we talked about prematurity, and I think so. Remember, in premature cells, usually there are high chances of bleeding because of fragile, blood vessels in the periventricular area. So you can get bleeds around the periventricular area, which can later on develop fibrosis, and we call as periventricular leukomalacia. The periventricle means they are parallel and adjacent to the ventricle. This is one of the hallmarks of premature or prematurity related brain damage. And this periventricular leukomalacia can be picked up on MRI. So this is one of the most characteristic findings of MRI caused on MRI, which is caused by prematurity or any pathology related to prematurity. And this types of then pathologies over here, because all around this your periventricular area are the white tracts. These are the axons of the upper motor neurons passing through that. So obviously your upper motor neuron signals would be affected going down, and that would lead to disorder of movement and posture. Okay, moving on to the pathophysiology. Now, the pathophysiology is because in brain the neurons are destroyed. So basically, these are upper motor neurons. So when an upper motor neuron is destroyed, what you get increased tone, especially spasticity. So there would be increased tones in the muscle, which we call as spasticity. There would be increased in deep tendon reflexes, and there would be the presence of chronos. So these are the hallmarks of when there is an upper motor neuron damage, and you will find them in kids with different types of cerebral palsy. Now, depend types of cerebral palsy. How we classify cerebral palsy. It depends on which part of the brain is affected, whether your pyramidal tracts or neurons are affected, or whether the extrapyramidal, like the basal ganglia and periventricular structures, they are affected, or whether the cerebellum is affected. So remember, if a part of the brain, like for example, if you see here, let's say the damage is just around this area, one part of the motor cortex over here. So what would happen? That would lead to, let's say, if it is partly, it would lead to monoplegia. If it's just one part, let's say up to this part. So what would happen? There would be weakness or paresis in just one part of the body. We call it as monoplegia. But let's say if it is extends to the rest of the motor cortex as well, so all your neurons over here would be affected, and that would lead to the lesions in the upper limb and the lower limb on the opposite side. So we would call it hemiplegic. So this is would lead to hemiplegic cerebral palsy if the lesion is on the whole of the motor cortex over here, but on one side. If both sides are affected, let's say over here, but small area of both sides, so what would happen, because mostly the lower limbs are represented medially and the upper limbs are represented laterally. So let's say the medial parts over here, if the bleed or the lesion is over here, so you would be getting lesions on both sides, but they would be lower limb. So this would be diplegia because both of your lower limbs are affected, so diplegia. But if it extends to, like, let's say not only the medial side but the lateral sides on the both as well, if you see over here, so you can see that it's affecting on both sides. That would lead to quadriplegia. So both upper limbs and both lower limbs are would be affected. But remember, most of the times lower limbs are more affected as compared to the upper limbs, again because damage is usually mostly in those areas where the lower limbs are represented. So you can have a monoplegic spastic cerebral palsy, you can have a hemiplegic spastic cerebral palsy, you can have a diplegic spastic cerebral palsy, or you can have a quadriplegic spastic cerebral palsy. Now, if the basal ganglia are involved on both sides, so you will be having abnormal movements which are not in control. So involuntary abnormal movements like this, which we call as ethetoid movements. So ethetoid movements, that we call it as ethetoid cerebral palsy. Then we can have dystonic. Sometimes the same lesions within the basal ganglion associated regions that can give you dystonia. And dystonia means a sustained abnormal contractions. So these kids would be having abnormal posture. So they would represent in abnormal postures, and that we call as dystonic or dyskinetic cerebral palsy. Or if it affects the cerebellar cells, then you will be having ataxic cerebral palsy. So these kids would be, would be having problems maintaining their balance, and they would be walking with a broad gait, ataxic gait. So remember, it is spastic cerebral palsy. You have got dyskinetic cerebral palsy, and you've got ataxic cerebral palsy. So within spastic cerebral palsy, you've got spastic monoplegia, spastic diplegia, spastic hemiplegia, and spastic quadriplegia. So spastic monoplegia means only one limb is affected, might be upper limb, lower limb. Spastic diplegia means that both lower limbs are involved. Spastic hemiplegia means that one side is involved, one upper limb and one lower limb. And spastic quadriplegia means that both hands and both lower limbs are involved. Ethetoid means that they've got abnormal breathing, involuntary movements. Dystonic means that they have got abnormal postures, and ataxics mean that they have got problems maintaining their balance and they are walking with an ataxic gait. So hemiplegic cerebral palsy kids, if you see, if they are in the walking thing, you will see they will be walking with one arm flexed and having a circumduction gait. If they've got monoplegia, that one arm or one limb would be affected, and they would be having problems walking or doing work with that side. If they've got spastic diplegia, they would be walking with a scissors gait, so they would be crossing with their feet uh, curved inwards. And if they've got quadriplegia, not only they're usually immobile. So if they've got quadriplegia, not only they would be having scissoring of the lower limbs, but they would be having flexed, and rigid spastic upper limbs as well. So usually the upper limbs would be held like this, and the lower limbs would be crossed or scissored. Um, Ethitide, I told you that they can have abnormal like breathing movements. Dystonic would be having abnormal postures, and ataxic would be walking with a broad gait. But for practical reasons, many times the cerebral palsy types they are mixed as well. It's not only that the insult would only cause neurons in a particular part and not injure the other parts of the brain. Sometimes there are injuries in multiple parts of the brain, so you can have a combination. So you can have a diplegic and dystonic as well as ethetoid cerebral palsy. So that the child has got diplegia, he's got ethetoid movements as well, and he's got dystonia as well. So you can have any combination of these different types of cerebral palsy for practical from practical point of view. Now, coming to presentation, how do they present and how can we suspect that somebody might be having an cerebral palsy? In early infancy, it is very difficult to detect because usually the signs are very subtle and obviously they cannot be picked up that easily. So it can sometimes present as seizures, which is an associated phenomena with cerebral palsy. So seizures or abnormal movements in the early infancy or neonatal time period, they can later on, you would know that they are associated with cerebral palsy. Sometimes persistent of the newborn reflexes, most of them which they go away by 6 months of age. If they are persisting, that might be one of the clues that this baby has got cerebral palsy. Most of the time they present with developmental delay, so obviously they have got developmental delay on different domains. Usually the gross motor domain would be delayed. This is by and large one of the greatest delays that we see. So but then they can have delays in the fine motor and vision as well. They can have delay in other domains as well. As far as diagnosis is concerned, diagnosis is clinical. Remember, diagnosis of cerebral palsy is clinical. You don't need any test. It's only and only based on history and physical examination. So if you take a thorough history, you look for the risk factors, they are there, and the examination findings, they suggest cerebral palsy. That's your diagnosis. It doesn't require any test. But we still do tests. We still do neuroimaging. Why? It is not required for diagnosis. Remember, neuroimaging is never required for diagnosis, but it is used widely to see the extent of neuronal insult. So obviously, we want to see up to which level the insult is there and whether there are any associated features. So that is why neuroimaging is widely done. So MRI brain is still the widely used modality in cerebral palsy, though it is not. Remember, it is not required for diagnosis, but it is done. Then you can have some auxiliary tests like testing for hearing, testing for vision to see what is the damage to vision, what is the damage to hearing, and some other tests can be done and are usually done in practice. Here you can see an MRI brain image. So if you see here, there is attenuation of the signal in the periventricular area, and this is one of the commonest findings. I told you earlier that these are the commonest findings that you would find in uh, a baby who has got cerebral palsy as a result of prematurity. So this is periventricular leukomalacia. Remember, periventricular leukomalacia. So it happens in prematurity, and it can also happen in some of the congenital infections like congenital rubella or congenital cytomegalovirus infection as well. Here in the other MRI, you can see areas of hyper attenuation, different parts of the brain. This is basically toxoplasmosis. These lesions are caused by toxoplasmosis. So toxoplasmosis is a prenatal infection which can lead to cerebral palsy. Obviously, these kids have got bilateral cataracts. They've got chorioretinitis, and they can have a large brain as well. Uh, Fine. As far as the severity of cerebral palsy is concerned, the functional severity of the cerebral palsy, we divide them into three parts: mild, moderate, and severe. So mild cerebral palsy is like irrespective whether it is spastic, whether it's athetoid, whether it's ataxic. Remember, if it requires the child with that cerebral palsy requires minimal support to do his daily activities and is mostly independent, but may require some form of minimal support. Okay, then that is a mild cerebral palsy. If the child requires supports like orthosis and braces, he walks, he can do some of his activities, mostly dependent, but some of the activities he can do by having orthosis and braces, and that we could classify it as moderate cerebral palsy. And severe cerebral palsy are those who are completely bedridden, they are completely immobile even with orthosis and braces, they might develop contractions and things like that, and they're completely dependent. So remember, if somebody is mostly independent, he's mild. If he is mostly dependent, he is moderate. And if he's completely dependent, then that is severe cerebral palsy. So this is how we classify cerebral palsy on the basis of severity, functional classification. As far as treatment is concerned, it's all supportive. Remember, number two, it's multidisciplinary. So it's not a one person's job. It's usually you have to involve the physiotherapist, you have to involve the child's own doctor, a pediatric neurologist as well, and sometimes an occupational therapist, speech therapist, if there are problems with speech, and if there are problems with the child doing different types of activities. Most of the treatment in cerebral palsy deals with the problems and the complications as they arise. Remember, so these kids can have complications like contractures. They can have problems with spasticity. They can have problem with pain. They can have problem with intellect. So remember, the treatment depends on whatever problems and complications they arise. So kids, let's say, who have got problems with maintaining their posture and walking, they feel difficulty in walking or something, you can give them walking aids like frames or crutches, or they can have braces if they have got problems standing and maintaining their weight, so they can have like different types of braces and orthosis. Similarly, if they've got problems with eating and swallowing because the bulbar neurons are affected, or they can't swallow, or they've got regurgitation, they can have pack tubes inserted through which the feeds can be given. If they've got problem with hearing and vision, then you can correct hearing by giving them hearing aids. If they've got problems with vision or have got like squint, so squint surgery can be done. Refractive errors can be treated with glasses. Similarly, if they've got problems with their joints and contractures, so physiotherapy can be done to prevent contractures. Similarly, those who have developed contractures or developed limb asymmetry, tendon lengthening procedures can be done by orthopedic surgeons. If they've got problems with the sleep, then different types of medications are available, like melatonin can be given to, maintain their circadian rhythm. If they've got problems with spasticity and pain, then different types of like antispastic medications can be given. Like, for example, intramuscular botulinum toxin can be injected, which works by relaxing the muscles acting at the neuromuscular junction. And one injection is good enough for 5 to 6 months. They can be given anticholinergic drugs like benztropine, which can help with dystonias, which can help with drooling and secretions and hypersalivation. It can also help with different types of dyskinetic movements as well. Similarly, we can give baclofen and diazepam to control spasticity. And if they've got problems with their psyche or behavior, then psychologist input and psychological, sort of support treatment should also be given to these kids. So, in a nutshell, these kids, they require multidisciplinary approach. And as I told you, that most of the treatment is not for the underlying, because whatever damage has been done, neurons cannot regenerate, you cannot reverse that back. The issue is now the complications and the issues which arise because of this damage to the neurons. So it is non-progressive, but whatever damage has been done, that has been done, that might lead to certain complications. So those complications have to be treated as they arise. And again, as I told you, it's a multidisciplinary approach which looks at different things as they arise. So this was a brief lecture about cerebral palsy. I hope you have understood the main concepts, especially the types and the treatments and the underlying pathophysiology. Still, if you've got any questions or something which is not clear to you, you can put your questions down in the comment section below, and I would answer them as soon as possible. And if you have liked this lecture, and if you haven't subscribed to my channel, please do subscribe and share my videos with your friends. So have a very good day. Bye bye.